تأخير. أنا الدكتورة خلود وشاح من كليفلاند هون بأوهايو بأمريكا. Allergy Immunology. أنا في مترو هيلث هوسبيتال. نجرب هلا إنه بدي أبدأ هلا في عنا two presentations. The last time صار في شوية confusion عشان كان عندكم تغيير وقت فراحت علينا. هاي هي المحاضرة Allergic Rhinoconjunctivitis، وهي اللي حابة إنه نعملها هلا بدال الإميون deficiency ونشوف وقت تاني مع الدكتور رامي للإميون deficiency. Allergic Rhinoconjunctivitis, I chose to talk about this subject because it is a very common disease. It's one of the most common chronic illnesses that goes, it's taken lightly sometimes. يعني ما بنشوف إنه allergic rhinoconjunctivitis is a big deal، بس هي إلها big impact على cost of medical care and the patient's life. Of course, the numbers I have are mostly the numbers that we have in the United States. It affects up to 40% of the population in the United States. Its importance too, other than being uncomfortable for the patient, is the association with asthma. It affects anywhere from 15 to 38% of patients, the association with asthma. When you have uncontrolled allergic rhinoconjunctivitis, and it is moderate to severe, it also affects asthma control. فهون بتيجي كمان أهميتها. Allergic rhinoconjunctivitis affects quality of life, impaired sleep, impaired cognitive function, and we see it بالتحصيل العلمي كمان للطلاب. After we treat, اللي بنسمعه إنه الطالب صار بينتبه وبيركز وعلاماته أحسن. Because when you're uncomfortable, you can't breathe, or you're itchy, you're irritable, you're fatigued, وفي عنا impaired sleep زي ما حكينا, leading to the decreased school performance or frequent visits to the primary care physician. In the United States, the annual indirect medical cost that is associated with allergic rhinitis due to lost work is more than that associated with asthma. The other thing is the total cost of over-the-counter medications for allergic rhinoconjunctivitis is in the billions. This summarizes the allergic response that we see to allergens, سواء بالallergic rhinoconjunctivitis, بالallergic asthma, بالfood allergy. If you look at the top right, بيبدأ الexposure بالallergen. خلينا نفترض إنه الallergen here is olive allergen, which is of course common for Palestine والأردن. The allergen, when it enters the mucosal surface, سواء in the eyes or the nose or the airway, is going to be taken up by the antigen presenting cells. Antigen presenting cell example عليها اللي هي المacrophage. فالmacrophage will process the antigen and then it will present it on its surface bound بالMHC molecule. Now, when it presents it on the surface, it's going to present it to the undifferentiated T helper cell, اللي هي TH0 here. This cell, with the interaction in a patient who has the genetic tendency, of course, for allergy, he already has IL-2, interleukin-2, interleukin-4 abundantly, will change into a TH2, اللي هي ال T helper 2 cell, which is the allergy T helper cell. Now, the T helper 2 cell produces IL-13 or IL-4, and these are two major interleukins that are required to make the B cell start producing IgE, اللي كلنا بنعرف is the allergy antibody. The B cell normally produces IgM, but depending on the interleukins اللي around it, it switches its production to IgE, IgG, IgA, and so on. But in this case, because we have IL-13 and IL-4, the B cell changed its production to IgE. Now we have to keep in mind the IgE that was produced is now specific to the allergen that started this whole reaction. So this IgE from now on will only respond to olive allergen. Now this IgE will go and it will sit on the surface of the mast cell. Now we have a mast cell that has IgE on it that can recognize olive allergen. Now, the next time you're exposed to the olive allergen, you see the allergen again at the bottom of the screen. If it causes cross-linking, مش بس linking to one Ig molecule, it has to cross-link more than one. This will lead to activation of the mast cell. Activation of the mast cell will lead to release of mediators. The main mediator that is produced at first is histamine, and that is the one that is going to cause most of the symptoms that we see in allergic rhinoconjunctivitis. Now, the allergic reaction in general has two phases, the early phase and the late phase. These are important because it helps you in deciding how you treat the patient. The early phase reaction is what we just saw, اللي هو predominantly mediated by mast cells. The allergens cross-link the specific IgE on the mast cell, so it leads to mast cell activation and histamine release. Now, histamine, we all know, causes vasodilation. So when we have dilation of the blood vessel, there's going to be congestion, بصير في عندنا swelling and edema. And that's why you get the conjunctival edema and you get the nasal congestion. Increased vascular permeability, بصير في عندنا leakage of clear fluid, not blood, clear fluid out of the nose. فبصير في عندنا runny nose and postnasal drip. بعدين ال itching effect. Now the late phase response. If the allergic reaction continues, when exposure continues, there is going to be release of other cytokines and chemokines by the mast cell. The result of this is attraction of eosinophils and other cells, زي basophils or neutrophils, into the area. This kind of reaction happens about 6 hours after the exposure. Now, in this hadal phase where you see release of leukotrienes, and I'm bringing this up because we all know that Singulair is one of the medications that is used to treat allergic rhinitis. But if you think of it, the leukotriene is majorly seen or mainly seen in the late phase response, and it is not the major chemical mediator that is being produced. So Singulair alone, as a single medication for allergic rhinitis, is not a good idea for therapy. We always combine it with an antihistamine to be effective. The other thing to take away from the late phase response is not every patient who comes to you with allergic rhinitis will have sneezing, itching, runny nose. Mostly, some patients will come with only nasal congestion. And that is the symptom that is mainly seen in the late phase response. فإذا إجاني المريض على العيادة وبيشكي بس من chronic nasal congestion، ما بقدر أحكي إنه هذا ما عنده allergic rhinitis لأنه ما في sneezing و itching. لا، إجاني وهو past that early phase reaction. هلا, classification of allergic rhinoconjunctivitis, perennial allergic rhinoconjunctivitis, اللي هو symptoms are year-round, and usually these patients have an indoor allergy. وموست commonly هي الدست مايت اللي هي عفة الغبرة، مش الغبرة نفسها، عفة الغبرة. لأنه في chronic exposure, and these are the patients who usually come with more nasal congestion than the other symptoms. Or the other reason for perennial symptoms is back-to-back season, and do something in every season. Seasonal allergic rhinitis, and from the name, it's one season. Usually spring is the worst season for these patients. Intermittent and persistent allergic rhinitis. Intermittent, symptoms less than 4 days per week or less than 4 weeks per year. Persistent, more than 4 days per week or more than 4 weeks per year. Mild, does not interfere with quality of life. Moderate to severe, interferes with quality of life. هلا allergic rhinoconjunctivitis, it's an IgE mediated inflammatory disease مثل ما شفنا, characterized by one or more of the following symptoms: sneezing, itching, rhinorrhea, postnasal drip, congestion, itchy red, watery eyes, blurring of vision, or puffy eyelids. This is a very simple image of the nasal sinuses, the paranasal sinuses, but it's also very... One of the symptoms that patients with allergic rhinoconjunctivitis come with is nasal congestion. And if we think of chronic nasal congestion, what is happening is, if you look at the inferior turbinates and the middle turbinate, they swell up من الvasodilation اللي صار عنا. When they swell up, they are obstructing الostia of the maxillary sinus, the ethmoid sinuses, and the frontal sinuses, of course. Once you have obstruction, you have almost كأنه air trapping in the sinus and increased pressure in the sinus. And the patients come with sinus headaches, or they think it's a sinus infection لأنه عنده sinus headache. ممكن عنده tenderness on the sinuses, and at the same time في عنده postnasal drip that with time can be discolored. So we get patients who are referred for evaluation of immune deficiency, and all they have is chronic allergic rhinitis. Well, sinus symptoms are really due to the allergies. Now, the same thing happens, but more often in children, because their ear canal is more horizontal, so the drainage is more difficult. So this nasal congestion inflammation in the nose will interfere with the function of the eustachian tube. So you have more pressure in the ears, popping, and kids كمان بصير في عنا more ear infections. Keeping in mind the anatomy, if somebody comes with nasal congestion to me, I can't always say no allergic rhinitis. You have to keep in mind other reasons. One of them, اللي هي septal deviation. If the nasal obstruction is unilateral, معناته unlikely it's only ممكن عنده allergies aggravating it, but he has a baseline defect that has to be fixed. Usually it's going to cause unilateral obstruction or headaches or sinus infections. Other reasons would be nasal polyps. And if I see nasal polyps, في عندي a whole different differential diagnosis إله. And in younger age children or teenagers, I know this is internal medicine, but في adenoid hypertrophy can be causing nasal obstruction. So we talked about the eyes being itchy, watery, red, puffy, blurred vision, nose, sneezing, itching, runny, congested, snoring, or mouth breathing. Snoring and mouth breathing also can be due to the other reasons that we said, anatomy and adenoid hypertrophy. Ear pressure, popping, face pressure, or headaches. History of recurrent chronic sinus or ear infection. And then correlation with asthma exacerbations, atopic dermatitis flares. When you get a patient with allergic rhinitis, it's very important to know if the patient has asthma. And very important to know when the asthma exacerbation happens, the patient is having allergy symptoms or not. لأنه we find really effective controlling the allergies will greatly reduce the asthma exacerbations. We have patients who have severe eczema, who have beautiful skin all year, بس يجي عنا spring. أنا اشتغلت بالأردن 2 years. During olive season, the eczema flares are really bad in those patients. But that's another way. If you treat the allergic rhinitis by allergy shots, usually allergy immune therapy, you can eliminate the atopic dermatitis flares. Physical examination is going to be looking for everything we talked about. When you look at the patient, عنده puffy eyelids and allergic shiners. Allergic shiners are dark circles under the eyes, and they're due to venous congestion. When you look at the conjunctiva, it can be pale, it can be injected red, وممكن نشوف papillae, we'll see images بعد شوي إنهم, and discharge. When we look at the nose, من كتر ما they rub it upwards in nose, there's a nasal crease اسمها nasal salute sign. When we look inside the nose, عادة بنشوف pale أو bluish edematous mucosa and hypertrophied turbinates. هلا, why is it pale? لأنه في عنا eosinophil influx. But like we said, these patients are more predisposed to sinus infections. So the absence of pale mucosa, لما نشوفها it's inflamed, does not mean they don't have allergies. And we look for other signs in septal deviation when nasal polyps. If we look at this image, you can see there is injection of the conjunctiva, وكمان في عنا edema. It looks not shiny and it looks swollen, كأنها bubbly. High transverse nasal crease and nasal salute. You see a patient with this, even the adults, you know they have allergies. يعني ما بدها شطارة هون. If you look to the left, you see the enlarged inferior nasal turbinate. So if we see that, just think this swelling compared to the opening لل sinuses, لل osteomeatal complex, this is going to obstruct it. How do we diagnose allergic rhinitis? We have different ways of doing it. The ideal one, other than, of course, مع الhistory, you have to combine it, physical exam like everything else, is the allergy skin test is the preferred method of diagnosis. With allergy skin tests, it is very rapid. We get the results within 15 minutes. So the patient leaves knowing what they're allergic to. The allergen is applied to the skin epicutaneously. واللي هي بنسميها scratch allergy test. There's a second part of the test where we also, إذا ما طلع معنا results for the first part, we apply the allergen intradermally to see if that will trigger the reaction. We always use a positive control, اللي هو الhistamine, and a negative control, usually saline or the same base للallergens is included. We need the positive control, of course, لأنه إذا نسي المريض عم بياخد antihistamines, then I won't get any results, and I need to know that I have a good test. Now, if what we are doing, if you think of it, for example, I'm taking the olive allergen and I am applying it to the skin. If the patient's mast cells in the skin are carrying IgE specific to the olive allergen, it will bind to it, and those mast cells in the area will release histamine. They will cause vasodilation, increased vascular permeability in the skin. So I will see swelling and I will see redness, اللي هو الwheel flare reaction. If there is no IgE to the olive tree, nothing is going to happen. So I will get completely negative result and the skin will look clear. This is the kit that we use. If you look at the top, plastic on the top, that is, it goes down into a well under that level. إذا بتطلعوا على المستوى الفلات في عندكم هاي التip بنمسكها بتطلع من تحتها another tip that will scratch the patient. وهدول كل واحد منهم فيها فتحة فيها liquid different from a different allergen. Number 2, البلاستيك اللي in the middle is what we most commonly use. هاي اللي شفتوها قبل شوي اللي حكينا the top one is what we pull out. So there's the top والbottom إذا شايفينها is شوي sharp and that's where the liquid is and that's what we scratch the patient with. This is usually the result that we get on our allergic patients because most of the patients who come to us are the severe allergy patients. If you look, any of these, there's a big wheal flare reaction. The wheal is due to the vasodilation and the increased vascular permeability and the redness the same. Well, patient is very itchy. دكتور رامي أنا في حدا عم بيسأل سؤال أنا مش سامعة. Okay. هلا there are other ways of diagnosing برضو allergy, which is the blood test اللي كلنا بنعرفها بالRAS test. The RAS test, what they do is take a surface, a solid surface that has the allergen on it. Then they add the patient's blood. If the patient's blood has IgE to the allergen, the one they are testing, it will bind to it. They wash off the surface and then they tag it with something that they can quantify. Now, the RAS test takes time. ترجع. Well, sensitivity is not like the skin test, so we prefer the skin test for diagnosis. The chronic ocular allergic conjunctivitis, we have 2 chronic forms, vernal keratoconjunctivitis and atopic keratoconjunctivitis. Now the vernal, كلكم انتم بتعرفوا أكثر منا الرمد الربيعي, and it's more in the Mediterranean area. It's seasonal, it's mostly in the spring. Males more than females are affected. Onset less than 10 years of age. Usually it's outgrown or gone by puberty. It is common in the Mediterranean area. The increased mast cells, eosinophils, and lymphocytes, which tells you it's not just an acute phase reaction, it's gone into the chronic reaction. It evolves into a chronic inflammation with predominant lymphocytes. Intense itching, هدول المرضى. A thick, sticky mucoid discharge, whereas acute conjunctivitis بيكون watery discharge. يكون عندهم photophobia, foreign body sensation, blurred vision, ومن ال itching والinflammation can lead to loss of vision. You can treat with antihistamines, but usually you also need steroid eye drops. When you look at these patients for exam, بيكون في عندهم giant cobblestone papillae عادة على upper eyelid and the Horner-Trantis dots. These are the dots. If you see them at the limbus, they're collections of eosinophils. And these are seen commonly in vernal keratoconjunctivitis and other forms of chronic. This is the cobblestone appearance. وعادة, it's on the upper eyelid for vernal keratoconjunctivitis. Now, the atopic keratoconjunctivitis, It's more common in adults. وعادة هدول adults عندهم history of long-standing eczema, atopic dermatitis. It is perennial, it is there all year لأنه الeczema is there all year. Chronic severe itching, tearing, وهون عادة clear mucus discharge. It can lead to severe ocular damage, corneal scarring, and vision loss. عادة this is because of the severe intense itching اللي عندهم. And to the point إنه الcornea can get a cone-like shape which affects vision كمان. The eyelids, إذا اطلعتوا على هدول المرضى بيختلفوا كمان إنه the eyelids are thick وعادة they look eczematous وlichenified وفي scaling وflaking منهم. There's large papillae that are predominant in the lower tarsal conjunctiva. This is keratoconus. إذا شايفين الكورنيا إلها شكل مخروطي. Looks like a cone. وهي من intense itching. Of course, it's going to affect how you focus light and vision. هلا نبدأ نحكي على management of allergic rhinoconjunctivitis. The first thing, common sense, if I identify something that the patient can avoid, we have avoidance. Of course, it's hard to avoid the pollen outdoors في الربيع season, but we can do more of the indoor stuff. بنحكي لهم إنه دائماً في الربيع, for example, the house with car windows should be closed. They should avoid going outdoors في الأيام اللي pollen counts are high. وعادة pollen counts are higher in the morning. So they avoid going out in the morning, usually after 10 a.m. in general, and pollination is less. In the afternoons, it's less. بعد ما يكون في شتاء أو ندى, it's less. When the day is dry, windy, pollen counts are worse. We tell them to stay indoors if possible. If they have to go outside, they have to wash their face or shower when they come back indoors because you're washing the pollen off the face. Now, they also have to use the saline, normal saline eye or nose washes just to wash out the allergen in the nose or eyes. People who have indoor dust mite allergy, dust mites, اللي هي عفة الغبرة, is a small microscopic, you need an electron microscope to see them, my organisms. They feed on dead skin at night, so they're in the mattress with pillows. And they cause mainly nasal congestion. فالexposure تبعنا is mostly the bed. في special allergy covers that are sold, I'm sure they're available بفلسطين. You put a mattress inside them with pillows, or they have a zipper, وبيشيلوهم once a week وبيغسلوهم. These covers are made إنه في عندهم microscopic pores بحيث إنه بيحبسوا عفة الغبرة جوا الماترس أو البيلو. هلا we have a lot of medications you can use for allergic rhinoconjunctivitis. الأورال antihistamines رح نحكي عنهم كلهم. Intranasal antihistamines, intranasal corticosteroids, leukotriene receptor antagonist, intraocular antihistamines, بعدين subcutaneous allergen immune therapy, or the newest one, sublingual allergen immune therapy. Oral antihistamines, you all know these. The ones that we use for allergy are the H1 receptor antagonists. We have first generation and second generation. The difference, you all know, is the first generation cross the blood-brain barrier, and they cause a lot of sedation and impaired performance, and they have anticholinergic symptoms. Examples عليهم الدiphenhydramine والhydroxyzine والchlorpheniramine. Second generation اللي هم اللوراتيدين اللي هو الكلاريتين, cetirizine الزرتك, fexofenadine, الالlegra, levocetirizine الزيزال. These do not cross the blood-brain barrier, so they are preferred. But when they first came out, كانوا اللوراتيدين والcetirizine أول شيء. They said they were non-sedating, but there are reports of sedation مع cetirizine والlevocetirizine, but not common. So مش 100% they don't cause sedation. You have to be aware of that. If the patient says they're sedated على cetirizine, عادة your better option is loratadine or fexofenadine. Intranasal antihistamines. If you think of it, my symptoms in these patients are only in the nose or the eyes. So when I give an oral antihistamine after absorption into the blood or circulation, how much is going to the nose or eyes? It's not a high amount. ما في عندي high tissue level of medication, like if I put it in the nose directly. في عندنا intranasal antihistamines, there are two only, azilastine and oloptadine. They are very effective as initial treatment for seasonal allergic rhinitis. And first line, we even use them for non-allergic rhinitis. They act very fast, within 15 to 30-minute effect. And they are more helpful for nasal congestion than the oral antihistamines. Well, they give you a high tissue level in the nose, so extremely effective. Intranasal corticosteroids, you all know them, fluticasone flonase, triamcinolone nasoport, mometazone nasonex, budesonide rhinocort. They are preferred if you want to use monotherapy for persistent allergic rhinitis. Effective for moderate to severe seasonal allergic rhinitis. فإذا بدي أختار one medication للallergic rhinitis and I cannot use two, أحسن شيء is the intranasal corticosteroid. لأنه, you know, it's a steroid. It's going to block basically all the inflammatory response. It's very effective for nasal congestion. Oral antihistamine doesn't do much for. So it's the most effective monotherapy. هاي عنا على annual boards للresidents, they have this question a lot. Generally, no significant side effects in recommended doses. When they first came out, there was concern about cataracts, there was concern about growth in children, but they found is that we stick to the recommended dose ومش المريض طول النهار عماله بيحطه بأنفه, we are okay. We usually like the best ideal treatment allergic rhinitis if we can combine intranasal corticosteroid مع intranasal antihistamine. So we've moved away, for the more severe patients, we've moved away from using oral antihistamines as much. Leukotriene receptor antagonist اللي موجود mostly المونتيلوكاست اللي هو singular. It's most effective when used with an antihistamine and not as a single agent. إذا بتتذكروا in the first slides, singular is produced as part of the the leukotriene, is produced as part of the late phase reaction, but it's not the only chemical, it's not the major one. عشان هيك it's effective with an antihistamine. It's also a good choice in patients who have allergy and asthma. Then it works for both. When leukotriene receptor antagonist singular came out بالmid-90s, يمكن mid-90s, ما كان في side effects نسمع عليها other than people feeling fatigued or drowsy. But now in the last about 6 years, صار في a lot of reports of neuropsychiatric events, mood changes, severe depression, and suicidal thoughts. So the FDA here mandated black box warning على leukotriene, and we have to warn the family. I've had 2 families say that their children had mood changes, and I had one where the 5-year-old was hallucinating or talking to something in the room that nobody else could see. The thing about the effect, it's reversible, so you stop it and just avoid giving it in somebody who has psychiatric problems. وask السؤال, مرات ما بدك تحطه ببال الأهل, بس you can ask, did you see any behavioral change بعد ما أعطيناه? Systemic steroids, we avoid using systemic steroids لأنه this is a chronic condition and because of the side effects. But sometimes when we start therapy, we have to use a short course, say a steroid burst for about 5 days or 3 days, بس لأنه عندهم severe nasal congestion. And if I want to start a nasal spray, it's hard to get the nose spray inside the nose. Now, there is an older practice, we still have it here. Some of the primary care physicians will give the steroid shot in the beginning of every season. اللي هي usually الkenalog or triamcinolone. That is not good practice. We avoid doing it because this is a long-acting steroid. It's going to cause side effects, including adrenal suppression. الintranasal cromolyn اللي هو mast cell stabilizer. It is one of the safest medications in allergy. The problem is you have to start it several weeks before ما يبدأ season to have any effect. It's very safe, so it is a good choice in pregnant women because of its safety profile. The intranasal ipotropium is useful in perennial allergic rhinitis or non-allergic rhinitis if rhinorrhea is the main symptom. And sometimes we treat these patients and they come back, everything is good, but there is still a runny nose or dripping nose. We give intranasal ipotropium to dry it out. The intranasal decongestants, the nasal sprays, هدول are like a big no, big red X عليهم. Alpha adrenergic agonist, if we use them, and maybe once every few years, it's short use for only up to 5 days. ليش؟ لأنه with time, you have decreased response. بصير في عنا alpha receptor tachyphylaxis, and you need a higher dose to give the effect, and rhinitis medicamentosa. So the patient will have worse nasal congestion than they started. And when you stop it, the nasal congestion is severe. Oral decongestants, we also try and avoid, especially in the elderly with cardiac arrhythmia, uncontrolled hypertension, glaucoma, bladder outlet obstruction. For the eyes, we have intraocular antihistamines. Those are the best. They're the same generics as the, or formulation as the intranasal antihistamine, azelastine or oloptadine. They are antihistamines and they have a mast cell stabilizing effect. If we have patients who are not responding to medication, or patients who have side effects from the medication, or a patient who doesn't want to take the medication, then we go to the ultimate treatment, اللي هي desensitization of these patients. There are 2 ways to do it: subcutaneous immunotherapy and sublingual immunotherapy. اللي معروف مظبوط subcutaneous immunotherapy, it's been over a century, 100 years that we've been using subcutaneous allergen immunotherapy. It involves من اسمه a lot of shots. We use it, these are the indications. نستعملها للinhalant allergens. The indications, of course, are allergic rhinitis, allergic conjunctivitis, or allergic asthma. The newer recommendation اللي هي number 4 أو indication. Number 4 was added in the last few years, اللي هي atopic dermatitis associated with inhalant allergy. It's like the patients I told you about. They have nothing on their skin, and then in the spring they have severe eczema. Those are perfect candidates for this therapy, and usually we see no eczema after we desensitize them. Now, what we do, these are the indications again. We said patients who do not respond to allergy medication, ones who need higher doses of medications, or the ones with side effects. medication or can't afford the medication, and then patient preference بده يخلص من الالرجيز. What happens in allergen immunotherapy? The response for subcutaneous and sublingual in general is the same. نحن اللي بنعمله إنه we take everything or what the patient is allergic to. We mix them together in the vials لهالمريض. وبنبدأ نعطيه his shots. We cannot give a high dose or high concentration من الbeginning. بنعمل 4 dilutions in these patients. We start with the weakest one. Usually, in general, it's 4 dilutions, اللي هي about 1 to 1,000 dilution. We give him 0.05 cc the first week. He comes back the next week, we double it, 0.1 cc. We keep going in the same concentration from that same level vial, 1 to 1,000. He has to get a certain number of doses from that vial. Then he can move up to the next one, 10 times stronger. We keep doing the same in the next level, and then the third one until he gets to the full strength level. When we get to the full strength, we خلص the required doses. بصير يجينا once a month for 3 to 5 years. But it's a long process. Now, how is it effective? During this process, when we give small doses and gradually increase, we help the immune system generate regulatory T cells. These regulatory T cells, they produce cytokines. The cytokines they produce inhibit the inflammatory or the allergy response, اللي هم mainly IL-10 and TGF-beta. IL-10 decreases B cell antigen-specific IgE production. The B cell does not produce this IgE in response to the allergens we are giving it. We increase specific IgG4 production. بينزل ال IgE that can cause mast cell to produce antihistamines. وبيطلع عنا level of IgG4 that will bind the allergen اللي نحن بنسميه blocking antibody. So it blocks the reaction because it does not trigger the mast cell. It decreases the pro-inflammatory cytokine release, هاي ال end result من المast cell basophil eosinophils, وinduces tolerance. All of the above result in decreased lymphoproliferative responses to the allergens. At first, بكون في عنا TH2 mainly profile إذا بتتذكروا من ال first slides. With time, بصير TH1 cytokine profile instead of the TH2. The end result بينزل عندي ال IgE specific, بيطلع IgG4, ببطل mast cell و other inflammatory cell activation. هلا ال subcutaneous allergen immune therapy اللي هي الإبر, no age restriction on initiating it. يعني we can use it on babies. We have patients in our clinic who are 80 years old on it. It's administered subcutaneously in the MD office. Patient must be observed for 30 minutes after each injection لأنه في عنا risk of anaphylaxis. The most common side effect is local reaction at the injection site. هلا, anaphylactic reaction is what we worry about, and fatal reaction. Thus, the prevalence of severe systemic reaction is less than 1% in conventional schedules. الschedule اللي حكينا عليها اللي هي بيجي once a week and then once a month. In the United States, there are about 3.4 deaths per year, with deaths are mostly in patients with uncontrolled asthma. But if you have a patient with severe allergies and uncontrolled asthma, and you send him to Dr. Omar Abu Zaytoun, I am sure he will not start allergy shots until the asthma is well controlled. And if the patient shows up in clinic to get his allergy shots, there are questions he's asked before to see if the asthma is controlled. The other problem is systemic reactions. The systemic reactions اللي بنشوفهم are more common in the high pollen season. لأنه فكروا فيها المريض عم نعطيه الالlergen what he's allergic to, and at the same time he's breathing it in, stimulating the IgE production. Dosing errors new vial. لما يعملوا new vial بتكون fresh و very active allergens in it. The most recent or the newest treatment, and maybe in the last like 8 to 10 years, is sublingual immunotherapy. من اسمها بنحط الحبة تحت لسان المريض. It's only approved for allergic rhinitis, allergic rhinoconjunctivitis. Ongoing studies لسه للatopic dermatitis, oral allergy syndrome, food allergy, latex allergy, و bee sting allergy اللي هي الvenom allergy. Sublingual immunotherapy contraindications مثل subcutaneous usually. Severe unstable asthma مثل subcutaneous. History of severe systemic reaction to any form of immunotherapy. History of severe local reaction للsublingual immune therapy. ليش؟ subcutaneous, when you give it in the arm ويصير عندك severe local reaction مش big deal مثل لما تعطيه under the tongue ويصير عنده severe local reaction, because in this case when the pill is under the tongue and you have the severe local reaction, it means the tongue or mouth swell up. So this is a contraindication. History of eosinophilic esophagitis, because you are giving the patient to swallow eventually a pill that includes what he is allergic to, and we know inhalant allergies can aggravate eosinophilic esophagitis. Medical condition that increase risk of fatal reaction in case of severe anaphylaxis, say cardiac, people with cardiac disease. Now, one of the in a way, a bad thing about sublingual immune therapy, it's only available dust mite, ragweed, which is a bad allergy in the United States بالخريف, and grasses, which are in the summer and spring. Grass and ragweed need to be started 12 weeks before the season. Dust mite لأنه indoor allergen, it started anytime and continued all year. But if you think about it, لازم المريض يتذكر أو الدكتور تبعه إنه يبدأ treatment 12 weeks before the season. Grass and ragweed you can stop على طول بعد السيزون، يعني كل سنة يبدأ 3 شهور قبل وبعدين بعد ما يخلص تقريبا بده يضل عليه 6 شهور. Or they complete 3 years of therapy. After 3 years of therapy, improvement in the symptoms lasted about 3 years after 3 years of completing therapy. Dust mite allergy بضل عليها طول السنة لأنه it's an indoor allergy. The difference, the advantage to it, the patient does not have to go to the doctor's office each time. First dose is given in the doctor's office, observed for 30 minutes. But then the patient takes it on their own. ياخدها بالبيت. He must have an EpiPen with him in case he has a severe anaphylactic reaction. Tablet is placed under the tongue. He doesn't swallow anything for 1 minute, and then he can't eat for 5 minutes after it. Most common adverse effect are oropharyngeal, إذا صار عنده allergic reaction, we have swelling, or gastrointestinal. Side effects are rare. No preparation available for multiple allergen mixture, or no sufficient studies comparing it to the subcutaneous immunotherapy. فالadvantage بياخدها لحاله في البيت. Disadvantage إنه it's only available to limited things. فالمريض اللي شفنا ظهره بواحدة من السلايدات who's allergic to everything is not going to benefit that much from it. وهيك I am في أي أسئلة؟
العافية دكتورة.
الله يعافيك.
السلام
أنا بعرف يمكن استعجلنا شوي لأنه تأخرنا. بس إذا في أي أسئلة feel free. أنا اليوم عنا الأحد و I don't have anything. بعرف أنتوا يمكن مشغولين.
شغلة واضحة الأمور إن شاء الله دكتورة.
إن شاء الله. يعطيكم العافية.
شكرا.